Morning, everyone, and welcome to our March 2023 breakfast. My name is Karen King. I am the Community Affairs Liaison for the Office of New Haven Affairs here at Yale University. Our office hosts these monthly breakfasts on the first Thursday of the month during the academic year, unless otherwise noted. We have a great crew that is presenting tonight. I would like to make I'd like to make a few announcements in advance. The first is the Yale University Hiring Initiative has developed a partnership with the Dixwell Community House, the Q House, and they provide office hours, and they also host a series of info sessions from local employers about employment opportunities at their organizations. They are hosting sessions every Monday in March at 6 p.m. There is a sign-up sheet, and as you can see from this calendar, Yale Hospitality is presenting on Monday. All slots are filled. I'll talk about that in a moment. But Albertus Magnus is presenting on the 20th. Yale University Public Safety is presenting on March 13th, and on the 27th, the Cornell Scott Hill Health Center, their HR department, is presenting. Related to Yale's hospitality department, you may not be able to join them on their March 6th presentation. However, one of the items that they are going to be speaking about is their culinary apprenticeship program. The Yale Hospitality, in partnership with Local 35 Unite Here, are inviting a second cohort of people to join their culinary apprenticeship program. They're looking for passionate cooks and aspiring culinarians eager to hone their skills and further develop themselves as professional chefs. This is an intensive 32-week program. It gives people on-the-job training in partnership with Gateway. I will post a link in the chat for people to check out more information and apply. You can also reach out to the Yale New Haven Hiring Initiative if you have any additional questions. Next, International Women's Day is taking place on Wednesday, March 8th, and from 11:30 to 1:30, Yale's affinity groups are setting up locations around campus for people to get flowers from themselves or someone that they know in celebration of International Women's Day. Also, the Yale University Art Gallery is open, it's welcome, it's free and open to the public. There are a lot of things happening this month, especially with, they have rotating and ongoing in-person programming for teens. There are tours, there are highlights tours, there are furniture studies that are available. So I will put a link in the chat for you to check out their upcoming exhibitions. And one item of note is that the Yale Center for British Art is closed for building conservation. Some of their collection will be hosted at the Yale University Art Gallery, so you can visit there if you'd like to see some of the Yale Center for British Art's collections. And lastly, Saliva Direct, which hosted a location on the New Haven Green to offer free COVID testing, is going to offer mobile COVID-19 testing in the New Haven area. They have a form available for local organizations to fill out if they would like to host the mobile testing van at their site. I will put that link in the chat. So if you yourself can't take advantage of this, please think of churches, local nonprofits, and outreach organizations that would be a great site to host free COVID-19 testing. And now on to our speakers. So we have 4 great speakers this morning talking about the insulins and outs of type 1 and type 2 diabetes. We have El-Badawy, is a 3rd-year PhD student in the Yale Immunobiology department, studying methods of regulating tissue inflammation. He is excited to exchange conversations about immunology with everyone. Dr. Kristyn Carter is a soft tissue immunologist and currently a postdoc at Yale in the Department of Molecular, Cellular, and Developmental Biology. She is currently studying diabetic skin wound healing and how biomaterial incorporation can alter the chronic immune response seen in diabetic ulcers. Kavita Israni-Winger is a first-year medical student and just completed her PhD in immunology at Yale. She worked on inflammation and metabolism and looks forward to discussing those topics with everyone. And finally, Alex Dalrymple is a junior at Yale College studying molecular biology. She conducts research on immune tolerance in the Yale Immunobiology department. I need more coffee. And is looking forward to chatting about immunobiology. Please welcome everyone. I will hand this off to Kavita.
Hi, everyone. I'm so glad that you joined us this morning. I am having some connection issues myself, so I'm on my phone, but hopefully everyone can hear me all right. So today we wanted to talk to you a little bit about type 1 and type 2 diabetes. We know that this is something that a lot of people have personal experience with or know people who have experience with this. And we also know that it can be a little confusing, that there are two different types and that they're actually fairly different. So hopefully we can provide some information that you didn't know before today. And then at the end, we'll have some time for discussion and for questions. And I may bow out a little bit, but we have some really fantastic people here with us today who are actually experts on the subject. Kristyn, you can go to the next slide. Thank you. So Karen already did a fairly good introduction of us. I can let anyone else say additional things about themselves if they'd want. But as I mentioned, I'm Kavita. I am a first-year medical student. So I did research for 5 years, and now I'm learning how to be a doctor. And so I'm learning how to do both the science and the medicine. And it's a lot, but it's a lot of fun, and I really enjoy it. I don't know, Kristyn, Ed, or Alex, if you wanted to say anything.
Yeah, it was covered, very well by Karen. Thank you. I did my PhD and master's in immunology, studying soft tissue disease of the hand. And then now I'm applying my immunology experience to skin wounds and how they're impacted by diabetes.
Awesome. I'm just going to repeat what Karen said. And I'm Ed. I'm a third-year PhD student, so I don't have my PhD yet, as the others do. But eventually I'll get there. And so I'm currently working on immunology, in particular tissue inflammation. And I'm excited to be here today.
Great. Alex, did you want to add anything?
Sure. It's nice to meet you all. My name is Alex, and I'm a third year in Yale College, and I hope to be an MD PhD, so hopefully following Kavita a bit and becoming a physician scientist in the future.
Great, thank you. So today, Kristyn, Ed, and I are going to talk a little bit about the mechanism of diabetes, the history of diabetes, and then Kristyn's actually going to share some of her research with us. So that's going to be kind of a cool insight into what's being done currently in the lab. And Alex was a great resource for us and helped us put the slides together and gave us feedback on the presentation. So we're lucky to have her in the group as well. So to start out, I want to point out the obvious, which is that diabetes is highly prevalent in society. I mentioned earlier that we all probably either have personal experience with diabetes or know people who have diabetes. There are 37 million people in the US, and this, I believe, is stats from the CDC from 2020 or 2021. But 37 million people in the US, and that means that about 1 in every 10 people has diabetes. And there's an additional 1 in 5 people who don't know that they have diabetes. And one thing that we'll talk about today that I don't have on this slide is the prevalence of pre-diabetes, which are people who are at risk of developing either type 1 or type 2 diabetes. And that in itself is also highly prevalent. So it's important that we are aware that this is something that is highly affecting society, but it's something that could very easily affect you as well if you didn't know, or there are lifestyle changes that might be helpful to make. So we're going to go through all of that today. So maybe we can all have a little bit of a better understanding of how it's affecting people and maybe things that we can do to ensure that we ourselves are not affected by it or are less affected by it. Actually, one thing, sorry, Ed, that I wanted to point out before we move forward to is that while the incidence of diabetes is also high, I think it's something that a lot of people can live with, and it's not affecting our lifestyles the way it was, many years ago before we knew about insulin and were able to treat people. But there is still a mortality rate associated with diabetes, and there's a lot of extra health issues that people have who have diabetes. And so we also want to get into that as well today. And that's something that Kristyn will talk about. But first, I'll let Ed talk about the history of diabetes and what we should know as a foundation.
Awesome. Thank you, Kavita. So I just wanted to share a few things here about, because I found it very interesting to know the history of the disease and where its name came from. And I'm sure as many of us can guess, this is not like a recent disease which came out in the past few years. It's actually a very ancient disease, which goes back to 1500 BCE. So from the literature, the first described, like the first time diabetes was being mentioned or being talked about was in the early Egyptian manuscripts dating back to 1500 BCE. And they were noticing that there were some people they would claim in their Egyptian manuscript that there was too great of emptying of urine. So they noticed that some individuals have had more emptying of their urine as they describe it. And that was the first time that they noticed that there is something going on here. And around the same time, there were Indian physicians who noticed the phenomena, which was pretty interesting at that time, that there were individuals who their urine was sweet. So they call it the honey urine. And they noted that based on the fact that they observations that there were individuals, there were urine that would attract ants. So they noticed that there were individuals who had their urine was sweet. So and that's where the word diabetes mellitus came from. So the full name of diabetes is diabetes mellitus, and it's basically in Latin. Diabetes just means a passer through, which it comes from the too great emptying of the urine. So passing through just means that they empty their urine more, and mellitus just means honey or sweetened. And the word mellitus was added to diabetes later on, based on actually some individuals or some scientists who noted that the urine of some individuals were sweet, and that's how they called that's how they came with the word diabetes mellitus. And so that's where the terminology comes from. Next slide, please. So so after we talked about the history of diabetes and where the nomenclature came from, many of us may know or not know that there are two main types of diabetes. And diabetes in general is distinguished and characterized by sustained high blood sugar levels. So high blood sugar levels mean that there is diabetes, and there are normally two forms of diabetes, which are simply referred to as type 1 and type 2 diabetes. And in most healthy individuals or healthy individuals, we have the pancreas, which is the main organ involved in producing insulin. So insulin is what controls the sugar levels. So so we have two types of diabetes. So we have type 1 diabetes, which is that the pancreas does not produce insulin. And type 2 diabetes is actually the pancreas can still produce insulin, but we have problems of the insulin being used efficiently or being utilized efficiently by the cells to actually the cells can take up glucose. So these are the two main types. And if we go to the next slide, there's actually a table. Oh, so is there the table on the next slide? Yeah, so I might have messed up the orders here, but yeah, I just wanted to show like this table, which actually compares type 1 and type 2 diabetes hand by hand. So in type 1 and type 2 diabetes, so just to summarize again, type 1 diabetes, there is no insulin being produced, but type 2 diabetes, insulin is still being produced, but maybe not enough or not being used efficiently. So that's the main characteristic of type 1 and type 2 diabetes. Type 1 diabetes is usually developed during childhood, at the early stages of human life. And type 2 diabetes is mostly common in adults over 45. Type 1 diabetes just happens to have a sudden onset that just suddenly people realize that they don't have insulin in their body. But type 2 diabetes becomes more gradual. There is some family history related to developing type 1 or type 2 diabetes, but type 2 diabetes is more known to have predisposing factors such as overweight and high blood pressure. Unfortunately, for type 1 diabetes, there is no known prevention. If your body doesn't produce insulin, I don't know how you can prevent that. So there is no known prevention for type 1 diabetes, but type 2 diabetes, it probably can be prevented by a healthy lifestyle. So that's very good to know that, like, just developing a healthy lifestyle can prevent the developing of type 2 diabetes. And last thing is that type 1 diabetes is less prevalent, and the more common forms of diabetes, which we see in our everyday to-day lives, are type 2 diabetes. And sorry, can we go back to the previous slide just to a quick note that there is a third form of diabetes, which is called gestational diabetes. So gestational diabetes, it develops during pregnancy without necessarily having a previous history of diabetes. And so during pregnancy, it's been shown that 2 to 10% of pregnancies, they may develop some form of diabetes, and it resembles type 2 diabetes in many forms and in many ways. But fortunately, gestational diabetes, it can improve or disappear after delivery. Although, of course, sometimes there might be some interventions needed or some treatments needed to control it more. But this is another type of diabetes, which is also, we see sometimes, it's called gestational diabetes. Next slide, Kristyn, please. And yeah, we talked about this one, and now Kavita again.
Okay, thanks, Ed. So Ed mentioned briefly what the differences are between type 1 and type 2 diabetes, but I'm going to get into a little bit more what that looks like inside our body. So I'm going to start out very broadly and just note that, as all of you know, our bodies use different types of foods for energy. So part of the reason it's so important that we consume a diverse diet is because the different foods contain different types of energy that our body uses to keep running on a regular basis. Our body's favorite type of nutrients to use are fats, carbohydrates, and proteins. So you can see here good examples of all of those things. And our body can use all of them in order to produce the energy we need to function. But the body's favorite form of energy are the carbohydrates. Carbohydrates are just sugar. And in this case, or in science, we call that glucose. And that's important here for diabetes because glucose in the blood is a good measurement for how well your diabetes is controlled. And I'll get into that in the next slide. Thank you, Kristyn. Okay, so normally every day, glucose, which is circulating around in our blood. So when we eat it, it'll go into our stomachs and then it'll be absorbed into our blood and it'll just kind of go around our body. And normally the cells in our body can't use the sugars without help. So even if the sugars are there, we won't just randomly take it up. We have to get another signal first, which will be on the next slide. Thank you. So the body, as Ed mentions, produces insulin, and insulin tells the cells that they can now start taking up the glucose that they see in the blood. So I don't have the exact details written out here, but the insulin actually communicates to the inside of the cell and tells it that it can start using the tools it has to take up the glucose from circulation and use it to make energy. Every cell in our body can use glucose, but there are some main organs that we usually think of in regards to glucose use and are particularly affected by not having enough glucose. So our big ones are the liver, our fat, the brain, the muscle, and the heart. The brain is particularly important because glucose is its main source of energy. So it has to use glucose in order for us to keep functioning. But the big ones that we normally think of when we're discussing glucose transportation around the body are the liver, the fat, and the muscle. So just sitting here, my liver and my fat I'm not eating glucose right now, but if I were, my liver and my fat would be taking up the glucose to store it or to use it for energy. However, if I were to get up and run around the room, my muscle would start using that. And it would be really important for my muscle to access glucose because it produces energy the fastest. And then I would have the energy I needed to keep running around the room. Obviously, if my muscle couldn't take up glucose, I would have a much harder time doing that. So we know that it's really important for those main organs to be taking up the sugar. So when I say cell that takes up glucose, you can think of it in the context of your muscle if you're running around, or your liver or your fat cells if you're just kind of sitting down, but know that every cell does this. So when the cell sees insulin, it can take up glucose. And if there's more glucose in the blood, then the cell sees more insulin and it knows it can take up more glucose for energy. So if you only have so much food in your fridge, you're not going to eat all of it in one sitting. You're going to kind of eat it over time. But if you have tons and tons of food in your refrigerator, you know that you can eat more of it in one sitting. So this is kind of what the cell is doing when it sees all this insulin, is it takes up more glucose from the blood and uses it for energy or stores it. This means that we can control the levels of glucose in our blood, which are important for reasons that I'll mention in a minute. So how does the body produce the insulin when the glucose is present? Well, Ed mentioned this earlier as well. This is all thanks to an organ called the pancreas. The pancreas is kind of up at the top of our stomach, right underneath our stomach, and in between the first part of our small intestine. And when the pancreas sees glucose in the blood, it produces insulin. When the pancreas sees more glucose in the blood, you can go to the next slide, Kristyn. Then it produces more insulin. So we have this really nice sensor to tell us how much glucose is in the blood, how much insulin we need to produce, and how much glucose the cells need to take up in order to maintain our blood glucose levels. So there are differences in type 1 and type 2 diabetes in regards to this circuit that I just told you about. So in type 2 diabetes, insulin is still being produced, as Ed mentioned, but the cell, when it sees insulin, doesn't get the communication it needs to know that it should start taking up the glucose from the blood. This can happen if we eat too many fatty foods, which can lead to chronic inflammation, or if there is some sort of chronic inflammation that's present for other reasons. And why this develops is, I don't think, cut and dry. So we know that the chronic inflammation can actually affect the communication that happens inside the cell, and it dampens it. So it'll see the insulin, the cell will see the insulin, and it'll start the communication, but the communication won't go through. So the cell doesn't know that it needs to take up the glucose in the blood. The result of this is no matter how much insulin the pancreas is producing, the cells can't sense it. So there might be tons and tons of sugar in your blood, and your pancreas might be saying, take it up, there's so much sugar, here's some insulin, but your cells just can't communicate that, and they can't take up the sugar that they need. This means that we end up with really high glucose levels that can become dangerous and leak out into the urine, which is why the urine is sweet, as Ed mentioned earlier. Type 1 diabetes is a little bit different in that it's not the cells that are not responding appropriately this time, it's actually the pancreas. And the reason that happens is because of the immune system. So normally we have the immune system around to protect us from viruses and cancer and bacteria, but sometimes the immune system makes a mistake, and there's a whole host of mistakes that the immune system can make. But for whatever reason, one of the most common mistakes that it makes is it starts attacking the pancreas. Specifically, it attacks these things called beta cells, which are the ones that are responsible for sensing glucose and producing insulin. And when this happens, the beta cells start to die off because the immune system is attacking it. And you can see that on the next slide. Thank you. So when the beta cells are dying off, they can no longer sense the amount of glucose that is produced or that is taken up into the body. And so they can't produce the insulin necessary to tell the cells to take the glucose up. So in this case, it doesn't matter how much glucose there is. or how well the cells are responding to insulin, there's just not enough insulin. So the cell will see the insulin and it'll say, okay, I can take up glucose now and use it for energy. But if there isn't enough insulin, then the cell's only going to take up a little bit of glucose, no matter how much glucose is in the blood. So this means that that if you're eating a ton of sugar and you're not producing enough insulin, that you're going to end up again with those really high blood sugar levels. And this sort of goes both ways, where your body just can't control or tell you how much glucose is in the body. So sometimes the cells will take up too much and you're going to have low glucose in the blood, and not every cell will get all of the energy it needs to function properly. So this is why people who have low blood sugar, which means that their cells have taken up too much, they haven't eaten enough, oftentimes feel very faint. Sometimes they may actually faint. They feel low on energy. And then, of course, just like in type 2 diabetes, the converse is true, where you can have too much blood sugar, or too high blood sugar. And this can affect a lot of other organs in your body, and lead to certain extra organ, which basically means it affects other organs in your body, issues. And that's something that Kristyn will talk to you about now. Sorry, Ed.
Yeah, thank you, Kavita. So this is, with diabetes, we are fortunate that there are some therapies and treatments out there to help with diabetes. And because diabetes is characterized by having high blood sugar levels, the overarching goal of therapy and treatments is to maintain or restore normal levels of glucose, but with keeping in mind that we're not causing too low sugar levels. So diabetes, if you have too high, you want to bring it back to normal, but you don't want to accidentally bring it to being too low. So the aim of the therapy is just try to restore glucose levels back to the normal levels. And this is usually accomplished by multiple ways. And most importantly, in different forms of diabetes, is maintaining a particular diet, and with many dietary changes can help maintain or help keep sugar levels to normal, to healthy levels, and accomplished with exercise and weight loss. I would say these are like very important things when talking about diabetes therapies. And of course, appropriate medications are also needed sometimes, most of the times actually. So when we said that the difference between type 1 and type 2 diabetes, so type 1 diabetes, we said is characterized by there is a problem with producing insulin. So with that becomes the main form of treatment is actually providing insulin back. So that's why we see like insulin injections and different forms of insulin treatment. So type 1 diabetes, because there is a problem with producing insulin, then you give back insulin again. Type 2 diabetes, and also there are different drugs also used for diabetes, such as metformin, which is a very popular one. And also the same goes with type 2 diabetes. There's oral medication. Sometimes you need insulin, but with most of the diabetic cases, it's mostly just either oral medication, insulin treatments, and accomplished with different dietary changes, exercises, and weight loss. And next slide, Kristyn, please. And I just wanted to say something quickly that Kavita mentioned on the very beginning, that there's something called pre-diabetes, which is where blood sugar levels are higher than normal, but not high enough to be actually diagnosed as type 2 diabetes. Actually, pre-diabetes is very prevalent. So the statistics from the CDC say that more than 1 in 3 have pre-diabetes. And of those, 80% don't know they have it. So which is actually pretty interesting that their pre-diabetes is actually out there, very prevalent. But the fortunate thing about it is that pre-diabetes can be prevented and delayed with activity and diet. So when someone has pre-diabetes, is known to have like a little bit higher than normal sugar levels, actually just like maintaining a healthy lifestyle, exercising, weight loss, different changes in diet, that can by itself prevent or delay the development of diabetes. And it's very important to note these things, because if diabetes is left untreated, it can cause many complications. And one can imagine just having high blood sugar levels. No, of course, it's just having high blood sugar levels not untreated can cause many complications. And as these complications develop, there becomes a treatment for these complications. And what exactly the kind of complications can develop, I'm going to hand it over to Kristyn. She'll tell us more about that.
Thank you, Ed. So as my colleagues covered very nicely, diabetes is a very destructive disease. It affects different organs in a different way. And so on the research side, most treatments, I haven't listed them all here because it's quite overwhelming. Most treatments are specific to systems. For example, in diabetic retinopathy, this treatment focuses on reducing swelling. So one of the complications in the vascular system is in the ocular system, is that your vascular becomes disrupted. So your blood vessels are affected and blood can't get to your eyes, especially if you have like damage to your eyes, you don't recover as well. And it can lead to vision loss in most serious cases. And especially in the cardiovascular system, canagliflozin aids in glucose uptake in cardiac tissue. So as Kavita mentioned, when you're moving around and your body needs glucose to function, your cells need glucose to function. And imagine if your heart cells don't have the energy to function, what's going to happen? You're going to have heart troubles. And this is something that's especially prevalent in my family, which is what really drew me to diabetic research. And also in my family, foot damage is a complication of diabetes, leads to, in most serious cases, amputation or infection that can then spread through your body to other organ systems. So thinking about lower extremities, foot, leg, and how diabetes impacts it, it mostly circles around wound healing. And specifically with wound healing, the skin. So skin response is complicated by diabetes. Before we get into that, I'll talk a little bit about generally the skin and skin biology. So as we all know, skin is the largest organ of the body. It covers every inch of us. And there are several layers of the skin, which are focused on or calcified as the epidermis, the dermis, and the subcutaneous layers, including the muscle. And it's responsible for creating a physical barrier. So essentially it protects your insides from the outside world. And when you experience damage or you get a chemical on your skin, it's the skin's job to protect your body from receiving further damage. However, speaking specifically about tissue damage and wound healing, when you have a skin wound, unfortunately with diabetes, it doesn't heal. And it can remain as this open ulcer seen here on the bottom of the foot. These ulcers are super painful, very inflamed tissue, which is why it's really red and pink. But also having an open wound, especially on the bottom of your foot, can make you more susceptible to infection. And also tissue necrosis. That constant pressure on the bottom of your foot on that wound can cause nerve damage. And as I said before, can lead to amputation. And so thinking about the stages of wound healing and what can happen, I'll just go through very briefly of the stages of wound healing and the cells that are impacted. As Kavita mentioned, the immune system is really important with everything, really. But with skin wound healing, it's more targeted in terms of cells. So wound healing, the first stage is called hemostasis. And during hemostasis, the goal of wound healing is to stop the bleeding. So imagine you cut your finger and you put a paper towel on it and you squeeze. While you're squeezing inside your body, clotting factors are rushing into the site of the wound to try and stop the bleeding so that healing can occur. And this is the first stage of wound healing and initiates the next stage, which is the inflammatory stage. And in the inflammatory stage, your immune system sends tons and tons of immune cells through the bloodstream, through your blood vessels, to inflame the tissue so that more cells can arrive, and then to also calm the inflammatory response so you can continue rebuilding your layers of the skin during healing. And a couple that I want to point out are macrophages, neutrophils, and fibroblasts. So macrophages and neutrophils are really important because they communicate with other cells already in the skin, and especially fibroblasts. Fibroblasts are super important in the proliferative and the remodeling stage, as you see from the schematic here. The wound heals from the base upward. So if you don't have, fibroblasts and immune cells that are cooperating correctly or communicating at all, you then get those chronic open wounds that we saw in the previous slide. And then I won't go into the nerve damage side, but just remember those cells as we talk about skin wound healing. And so thinking about myself as someone whose family has been gravely affected by diabetes and diabetic research, a lot of diabetes research uses animal models. And when I think of myself, I personally don't consider myself a mouse or ever think that a mouse can be related to my health or my body. And so how is it that researchers can use animal models like mice or rats or, pigs to study diabetes? Well, geneticists have created these mouse models that essentially mimic the characteristics outlined by Ed and Kavita that are making them diabetic. And so specifically with my model of mice that I use a type 2 diabetic mice seen here. It's quite obese compared to the control mouse. It's got high levels of glucose in the blood. And with this specific type of mouse, type 2 diabetic DBDB, they have an impairment in glucose uptake. So it's a very classic case of type 2 diabetes. They're obese, they're not functioning well, their wounds don't heal, they have other organ complications. They're really nice and sweet because they're, large, but they have a really tough time living. And so essentially what we do with using this type 2 diabetic mouse model to then create wounds is I will shave the fur off the back, and using a 4mm punch biopsy tool shown here, I will create 6 even wounds on the mouse's back and watch it heal over time. And the timeline that I use corresponds to days that relate to those stages of wound healing I outlined previously. So day 1 and day 3 are classically defined as the inflammatory stage. Day 1 being more of the hemostasis, early inflammation stage, and day 3 is right on the cusp of the inflammation proliferative stage. And then day 5 through however many days I'm looking at will be the proliferative and the remodeling stage. And so this work shown here was actually done in collaboration with my summer student, Carlos Hurtado Muñez. He'd shown that with the control and diabetic mouse models wounds at day 7, so right in that kind of proliferative remodeling stage, we see really nice healing in the control mouse. So you make the wound, it goes all the way to the base, and the tissue has reformed. We see the really nice epidermis layer at the top, really nice dermal remodeling, as well as the fat layer below. However, interestingly, in our experimental mouse, diabetic mouse, the wounds are not only still wide open, but there's no tissue healing. And so what this shows us is that while the type 2 diabetic mouse is not an exact replica, because as I said, I'm not a mouse, you're not a mouse, this is a very good model to use as we see the delayed healing that's reflected in human ulcers, skin ulcers, and can also help us understand the inflammatory response chronic inflammatory response that we see in these diabetic skin wounds. And so thinking again about my research and the questions that I'm trying to ask, I return back to the stages of inflammation. And so one of the key characteristics described by patients who have these really painful foot and leg ulcers is that their tissue seems to be really hot to the touch. It's really red, it's inflamed. It's not a happy wound. And so which stage of remodeling do we think of wound healing do we think we should focus on given these characteristics? And my research focuses on the inflammatory stage. Based on published works and patient firsthand reports, we had suggested that the inflammatory stage in diabetic skin wounds is delayed and prolonged. So thinking about factors that contribute to these chronic skin ulcers, The initial healing response that's started by the hemostasis phase isn't happening, or it's happening very late, and then the tissue gets stuck in this inflammatory phase. So thinking about how diabetes impacts cell behavior, specifically macrophages and neutrophils and fibroblasts, could then help us understand why this tissue is so inflamed, why it's not remodeling, why the wounds aren't closing. And so my overall arching question is exploration of immune cells within the skin wound healing response. And so again, just refreshing, macrophages arrive to the wound site via the blood vessel. They infiltrate the wound site and interact with neutrophils, which also infiltrate the wound site from the bloodstream. However, when diabetes happens, this either doesn't happen at all, not enough cells arrive, or the cells that arrive just aren't really doing their job. And so typically with diabetic skin wounds, the focus is on wound care. But my research suggests that if we can figure out what's happening at the cellular level in the early stages, we can then prevent people from having to lose their limbs or become subject to further infection. And as I've outlined here, not me, but Sunrise Hospital Medical Center's image shows that wound healing is focused on keeping the area moist and protected from the outside world, which is the second fold of my research. So my research application side is how we can use biomaterials, which are just engineered materials outside of the body to control the inflammatory response. So in really serious cases of diabetic skin wounds, acid amputation occurs. Essentially what happens is the immune response is not able to be rescued, and it's just chronically inflamed tissue all the way through, and nothing can be done besides cutting off the affected limb and essentially hoping for the best. But what if during the early stages of wound healing, we can add an element that will completely change the immune response? Then that person can keep their foot or leg. So stay tuned, a couple publications on the way. But overall, my goals are trying to understand how the immune response becomes dysregulated or disrupted in diabetic skin wounds, and then thinking about tools for intervention. Especially tools that are accessible and don't involve big pharma or the complication of without access to healthcare. So as my colleagues have outlined, the history of diabetes and current treatments has really come a long way, and the research that's ongoing is super exciting. Not just my own, but other labs have done really fantastic work. I just hope that we have been able to show you the importance of diabetic research, and a really cool way to study diabetes is through using animal models. Thank you for your attention, and we'll happily take any questions.
Thank you. Lots of great information. So we have some time for questions. You can unmute yourselves to ask your question. You can raise your hand using the raise your hand function, or I will look at the screen and see who has a question. But here's my clapping hand emoji. Thank you so much, Ed, Kristyn, Kavita, and Alex. Great presentation.
Good morning. Thank you very much for presenting today, and thank you, Karen, for hosting. I really appreciated learning about the disease in a more scientific way. It's not necessarily something that I have done before, so I appreciate that education. And then congratulations on the progress in your research towards some new clinical solutions. Towards the end of your presentation, Dr. Carter, you mentioned, sort of finding the solution outside of big pharma, and obviously the announcement this week from Eli Lilly around price capping of insulin. And I'm not trying to insert politics into this conversation by any stretch of the imagination, but could you talk a little bit more? Because I'm actually not aware of how insulin is used as a treatment or prevention piece in the connection to diabetes.
Yeah, absolutely. So as Kavita has outlined, it depends on like whether you have type 1 or type 2. And so with diabetic injections, insulin injections, usually that happens when an individual isn't able to make enough insulin to take up glucose from the blood. So you need an outside source, the injection of insulin, to help that uptake. And then another way that could be kind of a challenge is you could have too much insulin and not enough glucose, or not getting too hairy with the cellular bits, but maybe your cell doesn't respond well to insulin. So maybe the insulin is doing its job, it's picking up the glucose, fabulous, it's bringing it to the cell. The cell is not then responding to insulin being there and then receiving glucose. And so that's a really tricky piece about the diabetic research side is, so the mouse model I'm using, we test its blood, the glucose is at the right level, it's too high, okay, perfect. But diving more into the genetic mutation of the mouse, so it has a deficiency in the uptake at the cellular level. So what about patients that don't have that same issue? Let's say, you yourself, your cells can take up glucose from insulin totally fine, but your challenge is you're not making enough insulin. So then how on the research side are we producing a model that reflects that? And
Great,
if Ed
thank you
or
very
Kavita,
much.
oh yeah. If Ed or Kavita want to chime in as well, they've also presented really great stuff.
I'm afraid I missed the question. I was getting in the car and I was disconnected. If you could remind me, I might be able to weigh in, but I'm sure you did a great job.
No worries, all good, thank you.
Good, great.
Jennifer says in the chat, fantastic and so informative. I agree. Are there any other questions or comments?
Hi, this is Tommy Shaw. I do have a question because now I'm totally confused. Well, I've always been confused about about diabetes anyway, because the two measures that they use, one is low something, the other is high something. If both readings are high, and so you look at the doctor and you say, well, how do I get the high number, the high reading down? And they just look at you. But Kristyn, I'm confused because you named like 3 areas that really need the glucose. How do you know which area is giving you the problem?
So the way that works is all your cells need the glucose. So it's not actually ever going to be just one area. We think about those organs because they're the most important users, but it's going to be the same across every patient in that if your cells are not responding to glucose, responding to insulin, none of them will be responding to insulin. And if your body isn't producing enough insulin, then none of your cells will have enough glucose. So as to why your doctor is not giving you solutions, that I can't speak to. I think maybe you should.
And you're right. It's just, speaking as a patient, this is kind of what you get. It's like almost being told, well, you need to diet, but they can't tell you what diet.
Sure. So that's, that is something that can be, so obviously what everyone wants you to do is go eat at Whole Foods, but that's kind of expensive. Not everyone has the time to be going to Whole Foods. And so it's something that hopefully if you had a good doctor, someone who was willing to work with you, you could learn to figure out together. I'm obviously not a full-fledged medical physician, but I would tell you, you want to cut down on things like chips and like really, fatty meats, or things that, things that like have a lot of processing, or, I have like a lot of, like anything that has a lot of sugar in it too, you want to watch. So in terms of diet, it's going to be what you can do that's best for you, but there are certain things that you might want to cut down on, like those, like chips, fatty meats, burgers, things that might be full of that kind of glucose that is hard on your body. But if your doctor's not helping you figure that out, you should find someone who can, because it is something that can be done. There's things that can be done, and it's not so individualistic that your doctor shouldn't be able to help you. would be my input. I don't know if anyone else wants to add anything.
Yeah, I'll chime in as well. Thank you for, being so open to share that your frustrations with understanding how to not only manage, but how to feel good. Because we don't want to just manage our lives, right? We want to be able to enjoy living and eating cake. I personally love cake. And I don't want to not eat cake, right? And so that's the research side is we look at people who do everything the doctor says, but it's still not working. People who, are marathon runners and eat kale and soil and weird stuff, but they still end up with diabetes. So it's these, while there is general, instruction about diet and exercise, sometimes that doesn't work. And that's what we're trying to figure out is maybe it's beyond just saying, okay, let me eat more broccoli and, less sugar. Maybe there's something in your metabolism or something at the specific cellular level within the immune response that's causing these challenges. So I completely understand your frustration. I do hope that you, as Kavita said, are able to speak with your doctor and have a conversation about your frustrations. But hopefully, diabetes has made a lot of progress in terms of treatment and research, but there's still quite a large way to go. And so maybe in the next, 100 years, we'll be able to say, boop, healed, done and dusted. But there is definitely room for more research, as you have just pointed out. So thank you.
Thanks, Kristyn. That's what I was trying to get at. They can tell you, have a healthy diet, but what is healthy for you? Because every individual is different. So, okay, thanks.
Exactly. Thank you.
Crystal in the chat says, excellent presentation. And she wants to know if diabetes can play a part in pancreatic cancer.
Not that I know of. Not that I know of, because those are, so there's two answers to that question. One of them is that with type 1 diabetes, I don't know of any known associations between diabetes and pancreatic cancer, because the immune system that's causing type 1 diabetes would not be causing cancer the same way. That being said, there's always more research to be done, as Kristyn mentioned, and there could be an association that we just don't know about yet. But from what I understand and what we know now, I think the answer is no. In regards to type 2 diabetes, one thing that causes type 2 diabetes is chronic inflammation, as I mentioned earlier. And that's, when your immune system is constantly working for one reason or another. In a lot of cases, it's because of the diet or the fact that we aren't getting enough exercise. And sometimes chronic inflammation can lead to cancer. Whether it leads to pancreatic cancer specifically, I don't know about. And maybe someone else can weigh in on this, but as far as I understand, there is no direct correlation or no direct connection between diabetes and pancreatic cancer from what we know.
So I'll jump in with not a counterpoint, but just more of like a suggestive remark. So as I've outlined, diabetes is pretty destructive in a lot of ways that we don't fully understand. And so it could be that diabetes can be an underlying cause of cell dysregulation, which could then lead to cancer. However, making a statement like, oh, diabetes causes cancers is a really extreme and scary thing to say. And so I try to use gentle, suggestive words, but thinking about metabolism and cell regulation, it could be possible that there is a connection. However, I won't say, yeah, you have diabetes, you're gonna get cancer, because that's mean and horrible. And the research isn't there to support that. But cell dysregulation is a complication of diabetes. And sometimes that it could possibly lead to cancer, maybe, but again, it's a speculation.
Thank you. We have time for one more question. If anyone has it. Crystal says, thank you for your response. Well, I know you all will join me in thanking Ed, Dr. Carter, Kavita, and Alex for joining us this morning. It was certainly very enlightening. This meeting has been recorded, so I will send out a link to this so that you all can share the excellent presentation that our colleagues here have shared with us this morning. So thanks again. And happy March to everyone, and we hope to see you at our April breakfast. Thank you.
Thanks, Karen.
Thank you.
Bye.
Thank you.